And I actually start straight in.
Yes, so you can start now, Trevor. Trevor, on to you.
On to me. Hello. Well, welcome everybody. This is great to see so many people signing in to this wonderful webinar, Coronavirus in the UK and US, Numbers Matter. What we know and what happens next. This is co-hosted with the Institute and Faculty of Actuaries, for whom we're incredibly grateful, and supported by the ILC Partners Programme. I'm Trevor Lanwarn. I'm a trustee at ILC, and in the UK, I was the government actuary for 6.5 years, up to August 2014, when I retired. Before we get started, there are a few housekeeping rules to go through. First, internet issues may affect sound and video, so please do bear with us if this occurs. At the bottom of your screen, you will see a chat function to communicate with panelists and delegates, as well as a Q&A feature where we will be collecting questions for the panelists. If you are having any issues with the audio or video throughout the webinar, please try to connect with an Ethernet cable or through hotspot on your phone. If you get disconnected from the webinar, do use the same link from the confirmation email to join back in. You are all invited to post comments on Twitter using the @ILCUK handle and the event hashtag #NumbersMatter. This webinar will be recorded and published for public access on the ILC website. The UK and the US have been heavily impacted by the coronavirus, but how many people have been affected and what happens next? Through this webinar, expert actuaries will highlight how COVID-19 has directly and indirectly impacted on death rates in America and the UK. We will learn who has been most susceptible to infection and death, as well as discuss what happens next. Our panel will then debate how the coronavirus may have impacted on longevity, retirement income and care. We will consider what the impact may be for demand for financial services products and what the industry may need to do to meet these demands. We will then also want to hear your views on what works and doesn't before launching into a Q&A session. Do submit your questions, please, to our speakers using the Q&A feature in the bottom bar of your screen throughout. And join the conversation on Twitter using @ILCUK and #NumbersMatter. Right, we will now get into 6 presentations, first 3 from the United Kingdom speakers and the second 3 from US speakers. We have an absolutely brilliant panel of 6 distinguished speakers. I'll list their names now and then do an introduction of each of them more properly just before each one is to speak. The 6 people who are speaking are Stuart McDonald of Lloyds Banking Group, Caroline Roberts of the Phoenix Group, Douglas Anderson of Club Vita, Ed Podlowski of Morningstar Actuarial Consulting, Max Rudolph, an independent actuary, Anna Rappaport is an actuary and consultant author. That's our wonderful panel. So it gives me great pleasure to start by introducing Stuart McDonald. Stuart is head of demographic assumptions and methodology for Lloyds Banking Group, where his multidisciplinary team are responsible for assumptions about policyholder health and behaviour. These are used for pricing, risk management and valuation of around £170 billion of pension and annuity policies. He also is very privileged to be actuary by day. So it gives me great pleasure to introduce Stuart McDonald.
Thank you very much, Trevor. I can't see the slides at the moment. I'm going to assume they are up. And I'll just see if I can make those visible. Okay, well, forgive me while I try to make the slides visible. On the first slide, you should be able to see a chart with some context. The all too familiar now charts showing the number of deaths that have occurred as a result of this pandemic. And you can see at the top just how many of those have taken place in the UK and the US. So good context for why we are focusing on those countries today. Clearly, those aren't adjusted for population size or similar, and hence they are, you know, a country like the US, for example, has a very large population. On the second slide, this is. I'm sorry, I can't see the slides. I wonder if there's anything that we can do. Excuse me, I am sorry. The second slide is a quick indication of the amount of different numbers which are floating around in respect of this pandemic and the potential that they have to cause serious confusion. If we could go on to the third slide, please. That actually gives you a brief walkthrough of three different measures of the potential fatality of this disease. So the case fatality rate, the infection fatality rate, and also the mortality rate. So you can see there is significant potential for confusion with these. For the case fatality rate, that is the number of officially confirmed cases divided by the total population. The number of deaths divided by the number of officially confirmed cases. The infection fatality rate is the number of deaths divided by the unknown total number of cases within the general population. And the mortality rate is the number of deaths divided by the total population. So you can see these are going to be radically different. The infection fatality rate in my example here is around 10%. So 1,000 deaths out of 10,000 cases. The infection fatality rate is 2%. So 1,000 deaths divided by 50,000, if that's the total number of cases in the population. And the mortality rate is 0.1%. You know, that won't actually be known until the epidemic is over. So within the UK, just to give you a broad indication, at the moment, the case fatality rate is about 14%. So we've had about 40,000 deaths out of 280,000 confirmed cases. The infection fatality rate we would have to estimate because we don't know for sure how many total cases there have been. But the latest ONS estimate is around 5 million. Hence, the infection fatality rate would be estimated at about 0.9%. And the mortality rate would be the total number of deaths divided by the UK population. So at the moment, that is sitting at about 0.1%. If we could have the next slide, please. This is showing you the CMI's mortality monitor. So the CMI is the Continuous Mortality Investigation, the actuarial profession's longevity wing. This is using death rates rather than death counts. That is the best way to look at this. And you can see the very dramatic impact of the pandemic. So it's visible on both charts. On the top chart, you can see how closely that black line tracked 2019, which is the yellow line, in the early months of the year. However, it's departed very substantially. And if you compare the cumulative death rate to date with that experienced in 2019, you can see that there have been 64,500 excess deaths in the UK to date. That is an estimate by the CMI, but most of the numbers that go into that are solid numbers. They are known and actual deaths. The uncertainty around it is really quite small. I think they're estimating something like 62 to 66,000. If we could go on to the next slide, please. I will, I think, just touch very, very briefly on this slide. This is the basic epidemiologist model, susceptible, exposed, infectious, and removed, and a description of what goes into each. I was a bit surprised the first time I looked at it at how little focus actually on deaths there is in the epidemiological models. The epidemiologist is almost ambivalent between whether somebody becomes removed from the susceptible population by virtue of dying, or removing themselves, isolating themselves, or becoming cured. We'll skip on. I'm going to go over some of these slides quite quickly. I talk rapidly at the best of times, and I'm conscious I've got quite a lot of material here, and you've got a number of great speakers. The next slide just shows you how easy it was to model infections early on in the pandemic. So although I was using a susceptible, infected, removed epidemiologist's model, I didn't really need to. I won't go into the mechanics of the model, but essentially the model implied around 43% or new infections a day, about 1 in 6 current infections recovering each day. So a growth of infections a little over 25%. So broadly, you can see that pattern of exponential growth, which was occurring early on. Now, this is a case-based forecast. That was all we were able to do at the time. There weren't adequate death numbers available. If we move on to the next slide, this is just a quick comparison of data sources. So there's a number of different sources available for data. You can actually look at plenty besides deaths when seeking to understand the pandemic. But I've just compared 3. So when I say plenty, to be more specific, you could look at intensive care admissions, you could look at hospital admissions, for example. This is just comparing 3 different sources of deaths information. So the first one, the DHSC figures, that is what gets announced each day by the government. They were initially just hospitals. Now they're all settings. There needs to have been a positive test. An alternative is the NHS hospital deaths. So that's released at the same day. It's daily at the same time. That's done on a date of death basis, which is far more helpful for those of us that are seeking to model and understand the progress of actual deaths. And then the golden sort, albeit delayed, is the ONS figures, the Office of National Statistics. So they publish once a week on a Tuesday with a little bit more information. You can see actually not just the different level of deaths included, but also the different trajectories. So for those of us trying to project, it's important to understand the direction of travel as much as the total number of deaths. On the next slide, a little piece about how we might estimate the transmission rate at any given time. So you can see here the estimating RT. So R0 you'll hear about a lot in the press. R0 is just the transmission rate at time t, at time 0 for R0. So I've shown here 3 different data sources: ONS deaths, NHS hospital deaths, and intensive care admissions. I won't go through the method of calculation, but essentially by comparing the progress of these time series and allowing for lag, you can use each to independently estimate what the transmission rate was at a point in the past. So deaths tend to occur maybe 3 weeks after infection, hospital admissions, intensive care admissions, maybe 2 weeks after infection. So you can back calculate and you can use each as a cross check on the other. So we can see there essentially how the transmission rate fell over time and has broadly stabilized. And it will be interesting to use these sorts of techniques to track it in the future. And indeed, you know, bodies advising SAGE are using similar approaches. On the next slide, there's a piece about comorbidities. So this is from a piece of work that I did with the COVID-19 Actuaries Response Group. Essentially, we were becoming quite concerned about the general message in the press that, you know, that these deaths were somehow inevitable, that they, you know, people were just dying with the disease rather than of the disease. You know, stories essentially say, well, many of the deaths are people age, you know, 75 plus with 2 or 3 pre-existing medical conditions. So what I sought to do here is make it clear just how common pre-existing medical conditions are at older ages, and, you know, why it is that, you know, that essentially that doesn't mean that people were in any way, you know, at death's door, or, you know, that death was in any way inevitable. You can see actually at the oldest ages, comorbidities are almost ubiquitous. So, you know, if somebody says to you, oh, they were 80 plus and with comorbidities, well, they're just sort of making the same point twice. An example we did was to look at the life expectancy of an obese male smoker, and you know, to compare, to take this obese male smoker. Obviously, males don't live as long as women. Obese people don't live quite as long as people of healthy weight. Smokers clearly don't live as long. And then we looked at their life expectancy with diabetes, heart disease, and chronic obstructive pulmonary disorder. And you can see actually, you know, even at the oldest ages, the majority of people had a number of years left to live. I should say probably care homes would be an exception to this. So about 30% of the deaths we've seen so far are care homes. And in those cases, you probably would expect that people had a shorter life expectancy ahead of them. But when looking at the general population, I think this is quite a good technique to show that many people had a long time to live ahead of them. On the next slide, I'm just looking to show the variation in risk geographically. Here I'm talking about risk of contracting the virus as opposed to the mortality risk, so the risk of surviving after the virus. You can see just how concentrated the intensive care admissions are into London. So London makes up about 1/3 of the cases that we've seen thus far of all intensive care admissions. So that's 1/3 of all the cases in England, Wales, and Northern Ireland. And that's really important when doing geographical comparisons. You know, it's all very well to compare the UK to a similar European country, but if they don't really have a London, then it's perhaps not a reasonable comparison. And you know, we see that in the US as well, where there's a great concentration of cases in New York City, but I will leave my US colleagues to talk more about that. On the next slide, we can see a little bit of a breakdown of, this is intensive care admissions data coming from the Intensive Care National Audit and Research Centre data. You can see that about 3/4 of admissions are males. You can see actually that the risk of getting admitted to intensive care is higher for men in their 40s than for women in their 60s. You know, a lot of the focus is on age, but you know, we shouldn't forget what a big risk factor sex is in this as well. And the second chart shows the ethnicity distribution. So considerably more risk of intensive care admission for people of Asian or Black ethnicity. I should say this is using the 2011 census to compare what the prevalence is in a given geographical location, and therefore what the admission rate ought to be. Clearly that census is 10 years ago, so there might be some changes to prevalence, but it does look to be a significant finding, and it's been repeated elsewhere. I'll go over these slides quite quickly because I'm conscious that Douglas is going to cover socioeconomic differences later. So just to show here that there is a significant socioeconomic gradient. There also appears to be an interesting relationship with BMI, body mass index. So we're seeing here that obese and particularly very obese patients are far more likely to need intensive care admission. On the other hand, those who are overweight but not obese appear to be less at risk. So quite an interesting finding. I'll turn now to a very large study conducted in the UK. I think still the largest study done to date with millions of NHS patients. Those in the UK will probably be aware of Ben Goldacre, the bad science guy. It's him and his team that ran this. And this is looking at exposure and mortality risk combined. I'm not going to major on this. I think Douglas will touch on this later, but you can really see here the breakdown of risk. You can see what a predictive risk factor age is. That is by far the most powerful predictor of your risk. But you can see the sex risk as well, about double for males. You can see the different risk that applies if you have various medical conditions or obesity and other conditions. So I will go to the next slide now, and a bit of a thought-provoking one, I hope, about what comes next. So we are living with considerable uncertainty here. So I have a model. Many organizations and government advisors as well will have models which allow people to project the course of the pandemic under certain assumptions. And these models do a great job of explaining what's happened in the past. But when you're trying to use them to predict the future, there are fundamental dependencies on what you choose as your parameters. So I've set out here 4 possible paths for what comes in the months ahead in the UK, based on everything we know to date about infectiousness, about fatality rates, about how many people have potentially had it. I've assumed that in these 2 cases, that the rate of transmission goes to either 1.1 or 1.2. So for each person that's got the disease, they infect either 1.1 or 1.2 people. So in both cases, the virus would naturally grow. I've then added 2 other variables, or sorry, 1 other variable. I've said either the virus is seasonal or it is not. If it is seasonal, I'm assuming it is 10% less transmissible during May to October. If it is not seasonal, then the same transmission rates apply throughout the year. And you can see these 4 very, very different projections. So if the virus is seasonal, and if we can keep the R to 1.1, you get the very bottom line, the thick dark blue solid line. If we can keep the R to 1.1, that's a natural 1.1. But then if it is seasonal, then you see the different patterns. And you can see that we can expect a later peak for the seasonal projections, whereas we can expect an earlier and potentially significantly higher peak for the non-seasonal projection if R is 1.2. I think at that point, having rattled through, we'll close and hand back over to Trevor for the next question, the next speaker. Trevor, you're on mute.
Thank you, Stuart. That was brilliant. Lots and lots of information. So without further ado, let me move on to our next distinguished speaker. She is the Longevity Risk Manager at the Phoenix Group, the largest specialist consolidator of life assurance and pension funds in Europe, with businesses in the UK, Germany, and Ireland. With over 10 years of experience in longevity models and assumptions, she is the leading longevity expert within the Phoenix Group, and in recent years has played a major part in the development of their internal model, longevity assumptions. She has a particular interest in understanding the drivers behind historic changes in longevity and how these may change in the future, as well as furthering understanding behind socio-demographic differences in longevity. So without further ado, it's my great pleasure to introduce Caroline Roberts to give us all the information on that, please. Over to you, Caroline. Thank you.
Thank you, Trevor. So thank you, everyone. I'd like to thank the International Longevity Centre and the Institute of Actuaries to invite me to speak today on this subject of the coronavirus under the title of What We Know and What Happens Next. So if we can move on to the next slide, please, and the slide next, actually, please. Thank you. So I thought this title was a useful place to start because it is essentially describing what I do in my day-to-day job as an actuary working for the Phoenix Group. However, if you have joined to hear what's going to happen next, I am going to warn you now that I'm often going to say I don't know. So my job involves taking historic data, analysing it, and then putting it into models and using it to try and make a prediction about what's going to happen in the future with respect to future mortality rates. So today I'm going to be talking about what I and other longevity actuaries will need to be thinking over the coming months and even years. So for any event that takes place that impacts rates of deaths, I need to consider what the impact's going to be on our business and whether it means that people will be living for longer or not. So many of these events take many years before we see the impact, for example, the development of a new drug. So events such as this pandemic that have really immediate impacts are much rarer. And today I'm going to talk through what these impacts have been and how they're going to continue to impact life insurance companies over the coming months and years. So moving over to the next slide. So what we actually know for certain is fairly limited. But as Stuart's described, we've seen lots of numbers and we are starting to understand the risk factors. But I do think it's interesting to note that never before have we known on a daily basis what the numbers of deaths are from a single disease. And life insurance companies are maybe being asked to react to something much quicker than we ever have before because there's just so much information in the public domain now. Let's go on to the next slide, and actually there's actually a lot more that we don't know. So some of these answers will become clear relatively quickly, like is there going to be a second wave and what the pattern of deaths is going to be for this year? But others, we're not going to know the answers for years, such as how long any immunity is going to last for. For life insurance companies, the most pressing uncertainty that we face is what's going to be the impact on our portfolios. As Stuart mentioned, and as Douglas is going to go on to describe, the risk of dying from COVID-19 is different for different socio-demographic groups. And this means for a life insurance company, population data, which is what we are seeing so much of, it does have its limitations because our policyholders will have a much higher socio-demographic average than the population. So that means we should possibly look to in-house data, but that's unlikely to be available towards the end of this year. So for example, in your annuity portfolio, deaths and annuities typically take a few months to report. So if you're looking at experience data, which you might only receive, say, every quarter, we're not really going to see that increase in deaths that we see so clearly on the charts that Stuart just showed, actually within our own internal data. But the fundamental question for us companies is, as a result of this pandemic, will the future life expectancy of our policyholders stay the same, increase, or reduce? So going on to the next slide. So what happens next? So the impacts for life insurance companies are going to be seen over different time periods with no clear boundary between those periods. So in the short term, life companies are going to see an immediate financial impact that will hit our accounts this year. For companies that have large amounts of protection business, life insurance, they're going to see a large spike in claims with immediate demands on liquidity. For companies that also have annuity books, then there will be release of reserves as deaths are reported. But as I said, they will be seen a lot more gradually over the years because that death reporting is slower. Now, life insurance companies, we need to then estimate the life expectancy of those policyholders that didn't die this year and remain in our portfolio, so that we can maintain an appropriate level of reserves going forwards. Now, life expectancy will depend on current levels of mortality rates, as well as how those rates are going to change in the future. So how do we estimate those rates and how do they change in the future? So as many people will know, mortality rates in the UK and across the world have been steadily declining for a long time. Although in the UK, since 2011, this rate of decline has slowed, as the next slide will show. So on this slide, so this chart is one that's commonly used in presentations in the UK, as it demonstrates well how mortality rates have declined in England and Wales since the year 2000. Now, this chart's produced on an age standardised basis. All that means is that we adjust the data to make sure that we're isolating the impact so that we can just see the patterns of changes in mortality rates rather than changes in the age structure of the population. Because as a population ages, then we'd naturally expect to see more deaths. So despite that kink around 2011, you can see that the changes in mortality rates have actually fallen in a very constant manner. And it's relatively easy to draw a trend line through those points. So that then allows us to extrapolate future changes, well, at least over the next few years, relatively successfully. But on the next slide, I've added in a potential point for 2020. So now it's not quite so clear what our future trends are going to be. So is 2020 a true blip, so that the data is now in 2021 is going to go back to that previous trend line? Or is there going to be a new trend line from that point? So how do we predict those trends going forwards now? So on the next slide, so what do our actuarial models say about future mortality rates? Now, the starting point for all these models is the data that goes into them. Actuaries rely on vast amounts of data, and as I've said, we use both population data and internal data. Now, in 2020, we're going to see highly unusual patterns of death. So we need to decide, what do we do with that data from 2020? Do we include it, exclude it, or adjust it? Now, the answer is going to ultimately depend on what question we're asking of the data and how unusual we think 2020 data is. So if we want to look at an extreme event scenario, then we should keep it in the data. But if we want to consider a more normal or best estimate type scenario, and we think that 2020 is a true one-off, and that we are likely to refer back to normal levels quite quickly, then we should make some sort of adjustment. And to either remove it altogether or to make an adjustment to that year of data. It's useful to think of historic data as a combination of an underlying trend and short-term volatility. So I guess the question really saying is, how do we remove that volatility? So what goes on in that clever actuarial modelling? So normally that's just fitting a mathematical model to that historic data and then using the model to make projections. We might overlay projections over that just to allow for different events that we think that might happen in the future. But fundamentally, most actuarial models for projecting future mortality and longevity have as a starting point what happened in the past. So next slide. And I think it's probably fair to describe COVID-19 as a disruptive event. So does that mean that we've broken the chain between the historic data and future experience? So our reason for using historic experience is because of the belief that the patterns from this data are going to be repeated again in the future. But is this going to be the case? So on the next slide, I've set out some reasons why it may or may not. So what is going to happen? As I said, I don't know. And there hasn't been a similar event in modern history. So what will happen in the future is pure speculation at the moment. So the reasons that there was, first of all, there's reasons that mean that actually there could be a positive outcome going forward, and we see increases, quite substantial potential increase in future mortality rates. So for example, all of a sudden the population is really understanding the importance of vaccinations, and everyone's crying out for vaccination now. But according to Public Health England, in 2018, only 48% of adults who were in at-risk groups and therefore eligible for the flu vaccination actually took them up on that offer. So clearly there's some improvements that could happen there. By survivorship bias, I mean because we have potentially removed large numbers of people from the population who do have underlying comorbidities, that the population that remains will be healthier on average, which means that the mortality rates may be higher in the future. There's been a lot of support for the NHS, and we've seen also the really bad impact we've seen in social care settings in care homes. So there might be a lot of political pressure to increase funding into both of these establishments, which would have a positive impact. The hand washing message may carry on, and also as working patterns change, there will be potentially less congestion, less rush hour traffic, and falls in pollution, which would have a positive impact. But on the other side, there may be negative impacts. We're heading into recession, and historically, recession has led to bad outcomes on mortality improvements. People who've survived COVID-19, we don't know what that if there's been any underlying damage, which means that they may be more susceptible to death sooner than they would have been otherwise. There's been delays in treatment for cancer and other diseases, which again could cause increases in deaths on those causes over the next few years. And there's been falls in research funding. I mean, Cancer Research UK have already stated that they expect their income this year to fall by at least 20 to 25% in the next financial year as a result of this pandemic. So what happens next is highly uncertain. Potentially, volatility in the future may be the only certainty that we face, unlike the smooth patterns that we saw in the earlier slide. So going on to the next slide, and what happens next for the actuarial models and any model that's being used to predict population demographics. So are they now all broken? There's so many uncertainties about what those drivers of change are going to be in the future. And it's tempting to say, yes, they are broken. I mean, we're currently seeing a lot of research and output from different models being published. Some of it appears to be contradictory and very quickly demonstrated to be wrong. But we are currently on a bit of a wartime footing, where the people trying to maintain existing models are trying to react very quickly with little time to respond and adjust. So I don't believe that they are all broken, although we may need to consider carefully how our existing models are being used. So just to move on to my final slide, and rather than saying that the models are broken, I suggest that we need to consider a change in focus. And we shouldn't be relying solely on models that are based on predicting the future based on what's happened in the past, because as we've seen, how relevant is that data up to 2019? So instead, we should be seeking input from other fields. Medical experts opining on what they think the future drivers of improvement might be, for example. And we should also remember the importance of sensitivity testing and using real-world scenarios. So what do we know? So there's been a tragic number of deaths, and we'll be seeing the impact of this pandemic for years to come. And there's still a lot that we don't know, but the amount and the speed of the research that's being published is astounding, and our knowledge is increasing with each report. So what happens next? So with regards to what the impact will be on mortality rates, I suggest that it's still too early to make any conclusions. And this is an important message that we need to make clear to our stakeholders, that we won't know for a while what the impact is going to be on future mortality rates. And no, I don't know how long a while is. So meanwhile, what should we be doing? We need to keep up with the latest research. We need to understand the importance of models, but making sure that the output is being messaged clearly. And we should think about a lot more collaboration across disciplines to get a more forward-looking view rather than just looking backwards. And that's all for me. So pass you back to Trevor. Thank you.
Thank you ever so much, Caroline. That was really brilliant. And I was thinking as you were talking, because you were very explicit, you don't have answers. That's opening up our audience to start asking questions to see if they can probe you a bit more.
So that's not exactly what I was hoping, but never mind. As long as they don't mind me saying I don't know.
So we've got a Q&A panel. I think we've got one question on it so far. See if I can use this as the opportunity to get people started. Thank you ever so much, Caroline. Lots of important messages there. Our next speaker is the founder of Club Vita, which specializes in applying modern data science techniques to innovate in longevity and mortality risk management. He is a fellow of both the UK's Institute of Actuaries and the US's Society of Actuaries, and a chartered enterprise risk actuary. So without further ado, I'm really looking forward to what, Douglas, you've got to say, because I think it's going to be very important. Thank you.
Thanks very much, Trevor. I take my inspiration here today from George Bernard Shaw, who of course talks about two nations being divided by a common language. Today, I think we've got two nations who are both divided by a common virus. Some of this is sadly rather depressing, but I hope that this is going to be informative. I've tried to, rather like Stuart, tried to kind of share some of my observations in some of the interesting bits of emerging research that Caroline referred to. It seems like every day we kind of stumble over some new insightful bit of the jigsaw. So I'd like to talk about really both the kind of commonality between the experience in the UK and the US, but also the deep division within both of the countries, which is itself rather ironically a common feature of them both. So, sorry, let me see if I can get this presentation to move forward. So let's start off with the concept of longevity inequality. You may well be familiar with the Gini coefficient in economic terms. This is a kind of measure of the difference between the wealthiest or the most affluent people in the society and the poorest people, and it's normally used to kind of measure economic disparity. Here, in this particular application, the researchers have used it to look at the change in longevity inequality, looking at the differences between the longest living groups of people, the most affluent people in the society, and the least affluent. And you can see from the middle of the 19th century onwards, there's been a general downward progression, and indeed the UK and the US have kind of tracked each other kind of blow by blow all the way through that period. So it's a kind of remarkable consistency through all that period. And so during that time, we've seen the creation of economic prosperity through the Industrial Revolution, the improvements in healthcare through the introduction of antibiotics, and improved sanitation, and of course from the UK's Victorian times onwards. All of those things have contributed to reductions in longevity inequality. But of course, the question is, what happens next, and what relevance has this got to COVID? So, first of all, what happened next? If I look first of all at the at the east side of the Atlantic, at the UK, this is some analysis that my own business, Club Vita, produced, and we do what Caroline was talking about, of kind of dividing up the population rather than looking at a national average. We've divided the group of UK retirees that we track into 3 equal-sized groups, which we call comfortable, making do, and hard-pressed. That allocation is done both on the basis of where they live, according to the deprivation in the area that they live in, and according to how much money they receive in their pension. And it's really kind of the period beyond the financial crisis that we're interested in, because if you kind of look closely, you can see that there's a divergence in experience between the hard-pressed group, the bottom 1/3, and the top group, the comfortable group, where you can see that the comfortable group kind of continues merrily on upwards as if nothing's happened in terms of life expectancy extension. And of course, that's the group that Caroline is principally interested in terms of her policyholders, but the hard-pressed group plateaus, and you kind of see it goes straight across. Now, it's possible to get similar numbers for the United States. This is a piece of research by Raj Chetty, who did this, I think, when he was at Stanford University, is now moved across to be part of Harvard University. And he runs an operation out of Harvard University called Opportunity Insights. And here he's looking at the life expectancies of US residents grouped according to income quartiles. So that the yellow line at the top being the richest quarter of the population, and the blue line at the bottom being the poorest quarter of the population. If you look closely at those lines, this is from 2001 up through to 2014, you can see that the yellow line at the top has got a slightly steeper gradient. The blue line at the bottom is only just slightly tipping upwards, and arguably in the last few years hasn't been really moving upwards at all. But the difference between those two is about a year a decade. In terms of, if you kind of extrapolated them forward, it's about a year a decade of difference. So you see this same kind of pattern has happened up till, you know, certainly for the first decade of the 21st century. What's happened more recently? Well, this is more anecdotal because it's more difficult to get decent data, and the Chetty analysis in the United States stopped in 2014. But there's been much reporting at a national population level in the United States about the plateauing of life expectancy improvement, and indeed at a national level, life expectancy has started to become volatile and some years has reduced. In the most recent year, actually, there has been some improvement. The most recent available year, which I think is 2018, there was some increase. A lot of the previous increases are attributable to the sorry tale of misprescribing painkillers and people becoming addicted to these opioid painkillers. There seems to be some improvement in that experience now, which is what appears to have contributed towards some of the improvement that we've seen more recently. But again, anecdotally, one would not expect that the opioid crisis to have affected people uniformly through the population. So what about COVID? First of all, some international comparisons about where the UK and the US sit relative to their peer group. And so this is a bit extracted from the Financial Times. And if you look at the total number of excess deaths, and the FT is a little bit behind Stuart here, I think, in his figure, but which I agree with, by the way, that the CMI figure I think is pretty well substantiated by the evidence and is considerably higher than the UK government has so far admitted. We're seeing that the US is somewhat ahead of the UK, but the UK in terms of absolute number of deaths from COVID is in second place. Peru here, you'll see, is highlighted in blue, and that's because when you allow for the size of the population, Peru jumps to the top, and the UK is, and the US falls down the league table to what's that, 7th or 8th position, and the UK is now vying with Peru of all people for top slot in the rather gloomy, rather depressing top slot in this league table. Our Prime Minister in the UK said yesterday that he was very proud of his record, and it's rather difficult to see where he gets that proudness from at the moment. Now, if you look at, started to drill a bit deeper into the numbers, it's kind of useful to look regionally and locally, because of course COVID has a kind of clustering effect in this epidemic, people transmitting it from one person to another. And it was initially spread through international travelers dotting around the world. And there's lots of analysis you can look at which shows how it's kind of exploded out from travel hubs. If you look at the city of London and indeed New York, I'll put up New York beside it. This is from the local newspapers, as it were. This is from the London Evening Standard on the left and from the New York Times on the right. You can see that it's not uniform within in any of the boroughs of London or the boroughs of New York. In London, the worst hit areas are the London Borough of Brent, which is in the top left, the northwest of London, probably most famous for being the home of Wembley Stadium. The dark red area at the bottom is the London Borough of Croydon. I'm struggling to think of anything that Croydon is famous for, but somebody's going to put me right on that, I'm sure, in a minute. But you can see, more importantly, statistically, you've got 5 times the rate in Croydon and Brent compared to some of the other boroughs in London. A very similar pattern emerging within New York, and you can see on the New York map that it's bits of the Bronx at the top here, the north, and various little bits of Queens and Staten Island, where you see higher incidence, and those areas are highly correlated with social deprivation and also a higher Black population in those areas. Now, so what are the newspapers been saying about this story? Well, you can see in the UK that it's become it's become pretty obvious that the death rates are much higher in more deprived areas. And similarly, in the US, there's a very interesting article here, and if hopefully, and if anybody's interested, I've put links into all of these pieces, and you can go and look at them more detail. This article from USA Today had a series of very interesting descriptions of what's going on in different communities around the United States, and the sources of the deprivation that gave rise to the higher COVID impacts in those areas. One of the parts of the story is the occupations of people, and I've stumbled over this rather nice infographic. You can go and play with this thing. This is each of the blobs on this relates to a different occupation, and you can see along the horizontal axis you've got the proximity of people in that occupation to other people. And you've also on the vertical axis, you've got the likelihood of being exposed to disease, to the COVID disease. And you can see at the top right-hand corner, you've got health workers as being obviously a very high-risk group. Then, if you kind of exclude the obvious kind of key worker groups, interestingly, one of the groups which is deeply affected here, or more likely to be affected amongst kind of more regular occupations, is security guards. And security guards, if you look closely at the profile of security guards, you can see that 32% of those are from Black, Asian, and minority ethnic populations. And I thought it might be interesting to contrast those statistics with somebody in one of these blobs down here. And lo and behold, what did happen when I start clicking on the blobs down here? But I found actuaries, of all things, as being a particularly low risk group. We don't apparently have physical proximity to other people, and we don't get exposed to disease very often. Somehow we manage to avoid those two things. But also if you look at the composition here, there are more women compared to security guards. If I go back to security guards, you see 15% of security guards are women, and we know that being a man is a high risk thing for COVID, if you saw the statistics that Stuart put up a moment ago. We also know that there are fewer older people, only 7% of the actuarial working population over the age of 55, and a smaller ethnic proportion as well. So just on that question of ethnicity, a few weeks ago, 6 weeks ago, maybe, or thereabouts, we had a rather surprising headline in the UK when these frontline health workers unfortunately started dying from contracting COVID. It was discovered, I think it says here the first 8 UK doctors who died were all immigrants. I think it's actually more than that. I think it was something like 11 or 12 were all and largely of Asian origin, and this caused a lot of scratching of heads as to why this was. And, the health service in the United Kingdom has an above average proportion of people from ethnic origins compared to the rest of the population who provide services to them, and is very dependent upon immigrants to provide the services. We also saw this other headline that from the BBC subsequently a month later. We see that Black Britons are described as having twice the death rate from COVID. Across the Atlantic in the United States, this is from New York experience, and you see a similar gradient according to ethnicity. Although interestingly here, it's not white people that have the lowest risk; it's actually Asian people. But you can see that amongst the Black population, you can see a significantly higher rate of either contracting COVID or getting seriously ill from it. And then when there are multiple studies that if you start going Googling around, you can find all sorts of interesting studies to have a look at. This one relates to Boston and associates the increase in mortality with degree of poverty. There's a series of other charts in this study looking at ethnicity and population density and all sorts of things. And they all kind of show the same picture in a different way of a significantly elevated mortality rate in the towards the right-hand side of this chart, but it being significantly worse too for the people in poverty, excuse me. Now you saw this chart, this particular chart this is an extract, one part of the chart, which Stuart put up 20 minutes or so ago. And this is the Ben Goldacre Bad Science bit of analysis. He's one of many people at Oxford University who contributed towards this piece of analysis. What this makes this analysis interesting from a statistical perspective is for people who are comfortable with multivariate statistical analysis, is that it gives you a kind of a way of attributing the increase in risk down to or down to the individual kind of drivers or causes of it, and looks at it's kind of, as I understand it, this analysis looked at the COVID deaths in relation to the population of NHS records, and is picking up a whole variety of different factors and trying to attribute the differences in experience down to those factors. And you can see on this extract, this is not all the factors they looked at, but you can see ethnicity here, the relative risk of ethnicity compared to being white in here. But you can see the magnitude of these things compared to being obese. And you can see that being a class 3 obese person is much more significant than coming from an ethnic origin. And you can see diabetes down here, and similar to people from Black ethnic origin. But of course, what increases the risk considerably is associated with the combination of being obese, having diabetes, and being Black, and being old. It's the combination of all of these different risk factors together, which is, and being a man. You can see the difference between being a man compared to being a woman. So this kind of analysis helps to, points the finger really at the causes of the deprivation in the society being the contributory factor to why COVID has a worse impact, rather than COVID particularly hitting ethnic groups per se. So this is just intended as a quick little summary of the sort of things I've been touching on here. So when you kind of look at COVID and inequality, longevity inequality, COVID is a great example, if you like, of why you end up with longevity inequality, because you have kind of two things are happening. If this, on the right hand side, this is like the kind of model that that Stuart was describing earlier, that you go through these 4 different stages: catching the disease, needing hospital treatment, needing ICU, and dying or hopefully recovered is the other outcome at the end here. But in both the question of who will catch the disease and who's going to be worse affected, it's all about these kind of socioeconomic factors. You're more likely to live in a densely populated area. Lower socioeconomic groups are more likely to be dependent on public transport. They're less likely to be able to be socially obedient, and they're more likely to be in a job which brings them into contact with the disease in the first place. So shall I pause there? I hope that that's been helpful and at least stimulating some questions for the discussion later on. And now put my right hand foot across the Atlantic and pass on to the American side of the team.
Thank you very much, Douglas. We set at the outset to explain what the causes are, who's most affected, and what happens next. And I think all 3 of you have done a great overview of those 3 issues from a UK perspective. So thank you very much. It's now time to compare and contrast and see the similarities with the United States. And we start off on the care sector. So our first US speaker has more than 35 years of healthcare actuarial experience, consulting with large Fortune 500 companies. Prior to founding Morningstar Actuarial Consulting, Ed was a partner with Ernst & Young and a principal with 2 large employee benefit consulting firms. Ed started his career with a large health insurance company. He is an associate of the Society of Actuaries, a member of the American Academy of Actuaries, and a fellow of the Conference of Consulting Actuaries. Ed was the 2019 president of the CCA and chairs its healthcare community. So who better to get started on US and health and care than our next speaker, Ed Pudlowski. Over to you, Ed, please.
Thank you, Trevor. I'm going to rely on my fellow panelists to let me know if they're not seeing my screen at the current moment, as I can't see what's actually on the presentation. But I'm going to take a little different twist than my fellow panelists so far. So for my discussion today, what I'd like to do is really focus on the immediate and potential long-term health issues related to the pandemic in the US. This certainly will have an impact. Sorry, I guess thought I shared the screen, so bear with me. There we go. I think we're going now. So apologize for that. So what I really want to do today is focus on the immediate and potential long-term healthcare issues related to the pandemic in the US. This really aligns with the work that I do as a healthcare actuary and the financial modeling work my firm has undertaken for payers of healthcare, being the insurers, large employers, and other organizations that sponsor self-funded health plans, in addition to the individuals themselves. What I'd like to do is focus on it from 2 perspectives. One is the actual impact on health and longevity from the treatment of COVID-19, as well as the implications due to social distance policies and some of the things that we're seeing. So the first thing I'd like to do is kind of show you how I track what's going on in the US. And as the chart here shows, that we're looking at the daily new cases. And again, this aligns with my focus on healthcare and the financial implications of payers, because what this really does is give you an idea of the leading indicator of hospitalizations. And of course, it's also a potential leading indicator of deaths. If you look at the orange line and black lines, those aren't necessarily a best fit of the data, but they're really meant to reflect the trends. The orange and black lines are really meant to equalize the area above and below those lines, bounded by the actual data, which is represented by the blue line. At about the early part of April in the US, we started to see a decline from the exponential growth we saw prior to that. And that represented about a drop in about 2,000 weekly cases from that point in time. So we hit about mid-May. At about the mid-May mark, we started to see a little bit more of a flattening of our trend, and that's represented by the black line, which actually shows about an increase of about 280 cases per week. And I know that only extends to around the end of May. The information for the past week or so has continued that trend. But I'll indicate that there has been a little bit of noise at the beginning of that black line, because we did have some states in the US who were displaying both the not only the viral test, but the antibody test. And I know some of that data was removed and extracted by at least my state of Texas, but I don't know to what extent that other states were doing similar things. So there might have been some initial noise in there. But what I really think this information is telling us is that this uptick that we're starting to see, or at least the flattening, is a result of the relaxation of some of the social distance policies that we're seeing among many of the states in the US. And that's a little concerning. If we look at many of the hotspots state-wise, we see Alabama is very concerning right now, Arizona, California, Maryland, Minnesota, North Carolina, Texas, and Virginia. And what I display on this page really only shows those cases that are trending up and have 500 or more. There is an issue with the reporting in Georgia, delay and lag. I think that one probably should be added to this list. But clearly what we're seeing here is that there's been, in terms of the trend, there's been a movement away from The hotspots that I think we saw by Douglas's charts showing impacts in the Northeast to now starting to reflect some impacts in the South and the West. This graphic here provides you with the treatment path that we typically see as of an impacted individual. Of course, if you're infected, then the question is whether you're asymptomatic and don't require any treatment, or whether you're symptomatic, and then from there, whether you're going to suffer a mild case of COVID-19 or a more severe case. If it's mild, you're likely going to only need outpatient treatment, but if it's more severe, it could be a hospitalization and potentially could even result in movement into more intensive care. I think the issues here that are of concern is not only the potential cost, because there's a cost associated with each one of these green buckets, but also the severity of the illness and how it might impact people. From a modeling perspective, just to give you an idea, mild cases probably range anywhere from $13,000 to $35,000, before insurance kicks in. And then for the more severe cases could be upwards of $100,000 or more for those who require intensive care. So what that means for individuals in the US who have insurance, they're likely going to be hitting their out-of-pocket maximums. Those on Medicare may depend on what supplemental plans they have in addition to Medicare. So this could have a pretty big and significant impact on the financial situation of many individuals. But I think beyond that, and this is where most of our modeling has been going on in the US, understand that cost impact, but what I think has been missing from that so far is what are the kind of more long-term health implications. We already know that COVID-19 has pretty significant impact on damaging the lungs with potential scarring. There's inflammation of the heart or myocarditis. There's a number of discussions now about potential brain issues, from mental confusion, hallucinations, seizures, coma, strokes, paralysis, really resulting of how the virus invades the brain and starves the brain from oxygen. I think there's also some other issues too with respect to heavy doses of medications for those who are ventilated. Such as the narcotics and other sedatives that really act on the brain and induce delirium. There's been reports of loss of smell and taste, and some doctors are now starting to speculate that that may potentially be a permanent feature for many of these individuals. But I think there's also some impact on care treatment as well, as many people who require an MRI, particularly for those who may have particular brain injuries as a result of the disease, may not be getting the type of lab work they may need because of potential concern about infection and contamination of Medicare resonance imaging equipment, et cetera. Beyond that, I think there's some post-discharge issues. Patients may need skilled nursing facility, physical therapy, occupational therapy. Certainly there's post-traumatic stress syndrome with both healthcare workers as well as patients who survive ventilation. And then of course, on an ongoing basis, we're gonna have to, as we start to see the impact of a vaccine, I think that'll be an additional cost, and we'll have to monitor what that means in terms of long-term health implications. From here, what I'd like to do then is kind of talk about some of the social isolation issues. This shows the personal consumption expenditures between April 2019 and April 2020. In the US, and certainly you can see the impact that it's having on dental, physician, hospitals, home health, and lab services has been pretty significant. I think the prescription drug uptick, the best I can understand, I think that's really individuals who are getting maybe a 90-day supply over a 30-day supply at the beginning of pandemic, so they didn't have to venture out as much. And of course, there's been a pretty significant impact on nursing home, which is why I think you're seeing the uptick there. And I think private insurers are showing fairly similar results. This is results from CVS Aetna, one of the larger insurers in the United States, covering a lot of commercial Medicare, as well as the individual population covered by the Affordable Care Act. And I think the other, one of the other big players is United Healthcare is actually going to give back $1.5 billion in premium in June because they're seeing probably similar results. And so which are clearly seeing here is that there's been an avoidance of healthcare usage of healthcare services because of the fear of getting it contaminated when you do utilize the healthcare system. This chart gives you a little bit of an idea of kind of where we're seeing some of the big impacts when we look at inpatient procedures. A lot of these are non-urgent care that you would expect. Maternity, you'd expect to see that to be relatively flat, and of course, mechanical ventilation as a result of treatment for COVID-19 itself. What is more disturbing, I think, to me than anything else is when we start to look at it by disease state, and we start to see a more alarming pattern. People who are putting off managing their chronic conditions and avoiding the clinical setting. Probably the congestive heart failures, the 55% drop, the non-cardiac chest pains, 44% drop, probably are the most concerning to me, because these would seem to me to be those conditions where you would have otherwise gone to the emergency room or taken other care, and seeing those drops off is pretty concerning. In fact, there was a study done out of Paris comparing middle of March to close to the end of April 2020 compared to the years 2012 through 2019. And what they saw is that the number of out-of-home cardiac arrests actually doubled in 2020 compared to prior years. It went from about 26.6 million per population to 13.4. So clearly what we're seeing is people trying to avoid healthcare, and unfortunately we're seeing the avoidance of it even when they need that care. I think we're starting to see an uptick though, people starting to go back even though we're still in the midst of the pandemic. The survey by the Kaiser Family Foundation indicated that 82% of people are going to go to a dental or medical appointment in person within the next 3 months. And I think we're seeing that too in outpatient services, which again, I think would be a leading indicator. I think the first place people are likely to go back to the healthcare setting is in the outpatient setting. And so the real big question here, I think, and again, this is the other aspect of modeling that we have that goes on with the US is what is the impact of this change in demand due to social distancing and fear of using the healthcare system. And the question is what's the depth and breadth of that? How long will that take before people go back and we start seeing that pent up demand flow back into the healthcare system? What will be that impact on chronic care management? And what ability, quite honestly, will the healthcare system have to take up that pent up demand? Some of the conversations I've heard from physicians indicate that once the pandemic releases and the pent up demand starts to show, they may only be able to make up 25 to 35% additional capacity than what they were able to offer pre-COVID-19. So the question is how many people are going to go back? I know, certain laboratory tests, colonoscopies, mammographies, people may have put off right now and may not go back and get those done. That would be their desire. But then the question is whether the US healthcare system is going to have any capacity to pick that up. So I think some of the downstream effects on social isolation, and I'm sure many people listening here today may add to this, and certainly some of my panelists might. From a positive perspective, we've had a reduction number of automobile accidents because people just haven't been out on the streets as they've been complying with stay-at-home orders. Certainly a reduction in other accidents in industries. I know my niece and nephew have 2 young children, 2 and 4, keep telling them, quit jumping off the couch because we don't want to take you to the emergency room. There's been documented reduction in pollution levels, which I think can have some impact on health. Increase in virtual healthcare visits, which has made up for some of the drop in physician office visits, but some of the information that I've seen suggests that it's not making up for all of it. And certainly the legislative activity at the federal level within the United States, providing additional income to many individuals who may have lost jobs or aren't able to work as often as they had before, I think will help with some of the mental anguish over the isolations. But on the negative side, I think this can potentially more than offset some of those positive impacts. Certainly, we talked about the lack of chronic condition management that we're seeing. There are a number of behavioral health issues, anxiety, depression over the isolation and not being able to get back to work in a normal delivery, post-traumatic stress disorders from both healthcare workers as well as survivors of the coronavirus and the associated disease. We've seen an uptick in substance abuse. In the first part of March, the US experienced a 55% increase in alcohol sales over the prior year, same period. And certainly as the garbage truck rolls down the street and picks up our recyclable bins, I'm hearing more clinks of wine bottles coming in down the street. And there's also been suggestion of domestic violence out there as well. So I think there's a lot of behavioral health issues that we're going to have to keep an eye on. Organ and blood donations are down. Deaths from accidents actually are the biggest source of organs for transplants, accounting for 33% of all donations. So the positive impact that we had on the left side of there is having a negative impact on organ donations, and certainly blood donations have been down. In addition, I think income loss can have effect on healthcare decisions. If somebody feels they can't afford even the copay associated with a physician office visits, they may tend to avoid care going down. So those can have some long-term impact. Some public transportation systems have been shut down. And when we look at social determinants of health, there are a number of individuals who rely on public transportation to get access to healthcare. So that could have some impact now and in the future. And of course, physical activity and poor diets as a result of people being sequestered at home, maybe accessing the refrigerator more. I know myself, as I went back to work out at the gym this week, I'm probably about 70 to 80% of what I was able to do before. And I think to kind of put a pin to this point, I think most recently, the World Health Organization indicated that disruption of services is likely to create a long-term upsurge in deaths from non-communicable diseases. So I think there's, again, like Caroline, I won't pretend that I'm going to answer it. I think these are the issues that we need to pay more attention to for the long-term impacts. And certainly these can have not only long-term impact on morbidity within the US, but I think certainly can add to the issues that we're seeing around longevity that have already been discussed. So I want to thank you for your time today. I really appreciate it. And Trevor, I'll turn it back over to you.
Thank you, Ed. That was absolutely fascinating. And I love the way you spent so much time focused on impact in an area which I was able to relate to, and I'm sure many of the UK attendees were as well. And I'm sure it would be very similar. And of course, what we don't know over the next coming months is how much of the impact is caused by the choice of the individuals, or how much is caused by the lack of the provision of services in the first place on a lot of what you were saying. And in the UK, no doubt we'll find out over coming months and years. That's great. Next, I've got a wonderful speaker who's an independent actuary focusing on enterprise risk management and asset liability management. His clients have included investment managers and all sizes and types of insurance companies. He is an adjunct professor for Crichton University's Hyder School of Business, currently developing and teaching graduate level ERM and investment related courses. And I think this is really important to have an input on this within the panel and from the US as well. That's great. So it's wonderful to have Max Rudolph. Max, I look forward to hearing everything you've got to say. Thank you.
All right, thank you, Trevor. If we can go out another slide. One more, please. First off, I want to thank the Society of Actuaries staff. A lot of the slides that I'm using here, the charts are prepared for a report that the SOA has been putting together and been updating over time. There actually will be a new report out next Friday. I've been doing a podcast that goes along with these releases with Dale Hall, the managing director of research at the society, and I listed several of his staff who have been really helpful on this as well. I will note that much like the IFOA and other actuarial bodies, the CIA has a similar homepage to what I've listed here for the SOA. And then I'll note other sources that I use, and I think it'll be similar across the others on the that are presenting today. But the John Hopkins site is really good. I tend to follow the Washington Post site because it has more information by state in the United States. So that's one of the things I'm interested in. And then I know Stuart's referred before to Our World in Data, and that's just a wonderful site for so many different things. But Pandemic is another one of those. So just to make sure it's clear, the charts are from the SOA report, but any of the comments are mine. So if you disagree with anything I say, disagree with me. So next slide, please. This one is a fairly common chart, I think, now that we're starting to see. Note the dates that we've pulled this information from several different sources. And so the dates don't align quite exactly, but it's really percentages of how mortality rates by age have varied. This is population mortality, not insurance or pension. And it's probably not providing anything that's a surprise to anybody. I saw an interesting statistic just in the last couple days that Germany's use of restaurants has gone back up to 100% of what it was pre-pandemic. So that is very, very telling of the job that they're doing there. The rest of us have a long ways to go to catch up to that. So next slide, please. This one ties in with similar to a slide that Stuart showed, but it's for the U.S. and it uses on the x-axis the weeks of the flu season. The U.S. CDC puts out a regular report weekly during the flu season where they start right around October 1st as week 1. So it's not a calendar year date, it's a flu season date. And you can see a couple things I want to point out here on the far left where we're noting the 2009 and 10. I remember that flu season because even that little increase because of the timing, because it was right before Christmas, the hospitals in the U.S. really struggled to support the people who were coming in for that, for the serious flu that happened before Christmas, just from a timing perspective, from a scheduling perspective. And we've noted before, I think somebody else already noted that the 17-18 was a strong year, but you see, how big an increase COVID is relative to the flu. And I think these numbers are probably still underestimating what the total numbers are. We're getting to where you're starting to see more and more, both in the UK and the US, people backing into the numbers based on total deaths, as opposed to just what's actually on the death certificate. And I think that's going to end up being a better way of doing it. And it's interesting because that's actually how they do the flu on a recurring basis now. So that's kind of an interesting slide. Let's go on to the next one. This one looks at New York City only, and it's a chart that isn't going to surprise anybody, I don't think. The blue is male, the reddish pink is female. And really it does is it takes a group, and the group was 5,700 patients, and it's interesting because the total of the patients that are included in this chart is only 20. It's around 3,000 if I remember right. So there's a big group of that cohort that had not been discharged and had not died at that point. So my hope is that they will update this at some point. But the more we're able to see different differentiations and splits, the more useful it is. I mean, you can see that the percentage that die goes up with age. So that's consistent with other charts that we see. But you can also see kind of the cases where that's centered in that. And it, when this came out, it was when we were still thinking that it was only if you were 85 and above that it was an issue to get this. And so this came out, it was probably the first thing that I saw that was showing how many people down, especially in their 30s and 40s, were being impacted with these cases. And of course, now we're starting to see this inflammation, the issues that are getting into children, especially Black and Asian children. That you got what they call COVID toes, and it may be the same thing that's causing from the inflammation that's causing what Ed mentioned on the smell and taste. We also are seeing blood clots, and there's starting to be some research done around just the how the inflammation is impacting the blood vessels and whether that might impact everything else. It's still too early for me personally to understand that research. I need to see it a number more times before I have a feel for it. The other comment I'll make here is, we talk about New York City being a real where a lot of the U.S. cases started, especially early on. But I looked at the Washington Post site last night, and it's interesting that when you look at the deaths as a per 100,000, when you population affect it, that New Jersey, which is actually a state right next to New York, actually is catching up very quickly and may actually surpass New York State as a whole. Of course, New York, you have the heavy urban area in the city, and then you have upstate New York up towards the Canadian border that is much more rural. But still, New York State had a huge lead, in a category you don't want to have a huge lead in. And New Jersey is actually catching up very quickly. So let's move on to the next slide. This next one is from the same data set, but I was looking for something to compare and contrast against what the National Health System does in England. And of course, we don't have a single payer system here in the US. And so this was an interesting way of looking at, who was paying for those patients in the New York City area. And so you can see you've got 42% were paid by Medicare, which is the social insurance for age 65 and above. The commercial, that 33%, that's for people who have jobs, and you're also going to have some individual insurance involved there, but the majority would be what we would call group insurance. And then Medicaid is a poverty plan, generally paid for by the states, but often gets supplements from the federal government. One thing that surprised me about this chart, and hopefully they will update this one as well, is that self-pay. I mean, we have 8.5% is the most recent number I've seen uninsured in the US. And so I would have expected that self-pay number to be higher. But that could reflect that people who don't have insurance, didn't even go to the hospital. They just died at home on their own, because some of these cases come on so quickly. So obviously, if you're not in New York City, if you're doing the same study somewhere else, it's going to matter based on demographics, how many elderly you have, what type of comorbidities you have in that population. And as I mentioned, the urban rural would be an issue too. So, but it's maybe sets kind of a comparison for you. Next slide, please. This is one that a lot of you will say, well, why are you including this in a talk on COVID-19? And from an insurance perspective, the work that I've done, I do a lot of emerging risk type work. And so I've been looking at low growth and low interest rates, and actually had written a paper on pandemics back in 2004. That was how I got involved with it initially. And what I've come to believe is that insurance companies really think in terms of one event being able to survive that. It's when you get multiple events happening in a very short period of time that it tends to have a solvency issue. And so what we did was we just went out to a common database and pulled in, and we had actually done this in one of the earlier reports for January through March. And so now we're doing, April through June to show what natural disaster events can happen to form these clusters of risk events. And of course, we had, a 5.5 earthquake yesterday just outside of Los Angeles. You know, we've had, you know, flooding, storms, you know, there's a potential hurricane heading towards New Orleans right now. There's other things going on at the same time. So it's important as risk managers for us to be looking at how does this all work? How does this interact with other risks? One comment that I'm going to make here, no, I don't think we've really talked about it yet, but I mean, in the middle of the pandemic, we've had these protests in the United States, and I know they've carried over, and I believe they've been peaceful in London and other places as well. But one of the stories that we get out of 1918 and the major pandemic from that point is this series of parades that were held late, you know, to raise money for war bonds. And Philadelphia is the one that gets the most publicity. They had a quota of how much they had to raise for war bonds, and they hadn't hit it yet. And they were worried that the war was going to end, and you have a small window to raise that money before, you know, the opportunity is gone and people have moved on. And so, you know, my concern is that these protests are becoming another super spreader event, much as those parades were, those war bond parades. So that'll be something to watch over the next few weeks. Next slide, please. These last couple I'm going to go through really quickly because they could be entire hour presentations on their own. It's kind of, you know, what's the impact on actual practice? And Caroline hit on several of these already. You know, for life insurers, that's the one that I'm going to hit a little bit on here, because I think to some degree, and I don't know if it's a US, UK thing, but there's some of the things that she said that I don't completely agree with based on some work that I've done. You have the general issues with mortality, but in the US at least, mortality is actually a small percentage of the risk within life insurance companies at this point. If you look at the total profit from a life insurance company, you know, well under 10% comes from life insurance products. So it's kind of interesting. So the bigger issue for life insurers is based off of the assets, the drop in assets due to defaults and rating downgrades and things like that. You know, pension plans, kind of the same thing. I know Anna will talk more about that and the employment disruption and how that impacts everything. You know, health insurers, you know, maybe one of the things we'll talk about in the Q&A is how long-term care and nursing home evolves going forward from where we are today, because it's going to have to change quite a bit. And then property casualty, you know, you've been having, at least in the United States, a big discussion about business interruption and whether that's covered or not, whether it should be covered. And then you get into the systemic risk. You know, is this like terrorism where the federal government should pay? Next slide, please. Here, just real briefly, the point I've been making in a lot of presentations, especially to actuaries, is that we use a lot of rules of thumb, and that it's a good time to rethink those rules of thumb, to go back to first principles, to think about when you're strategically planning whether those will still work. Right now, the central bank is acting as a lender of last resort. In the US, there's a lot of BBB minus bonds that have been purchased to back on a reach for yield type of a basis. As those become fallen angels, the central bank is actually offered to buy those, which is a huge stopgap. And you know, you get into what's the moral hazard behind that? So we get into these what I call the unknown knowns, where historical data is not predictive, and so it'll be interesting to see how that plays out. Next slide, please. I'm just going to leave this one here. Maybe we can get into reasons why we might have stagflation. Certainly, I want to stay. It's like I muted myself accidentally, so I apologize for that. So let's go on to the next slide. I just that slide was more of just a heads up. And then this is my last slide, and it's more just a summary of things that I've come up with over the last couple weeks. It seemed like a topic that we were being asked about a lot more, what types of things. So I don't think there's really things in here that will surprise us. If there are, maybe we can come back to that in the Q&A. But you know, getting into places of work, you know, nursing homes, you know, public transit, places of worship, or you know, you see a lot of pictures in the U.S. of parties, and then people tracking that after the fact to show how those people did actually become a spreading event. So with that, I will turn it back over to Trevor. Thank you very much.
Thank you ever so much, Max. And it's so great that you've covered some areas which we haven't had covered so far, such as investment issues. And I particularly was grateful that you covered your casualty insurance, because it was one I was going to raise about general insurance here in the UK and business interruption and so on. This pandemic has had so many impacts in financial services that we've just had a super coverage. And thank you ever so much, Max. One gap that remains to be filled is our final speaker. Is going to be filled by Anna Rappaport. She is an actuary, consultant, author, and speaker, and is a nationally and internationally recognized expert on the impact of change on retirement systems and workforce issues. Anna is a phased retiree. I think that's the same as flexible drawdown in the United Kingdom. Anna is a past president of the Society of Actuaries and chairs its Committee on Post-Retirement Needs and Risks and Aging and Retirement Steering Committee. Anna is the co-author of several Society of Actuaries reports on COVID-19 and retirement-related issues. The issues that Anna is very interested in include creating opportunities for older individuals, retirement risk, and women in retirement. So it's great to have Anna on board to give us a talk through that missing gap so far of what's the impact on the individuals and their planning. Over to you, Anna.
Thank you, Trevor. Can we have the next slide, please? And the next slide. What I want to first point out is that I have not only a different focus because I'm thinking about retirement, but most of the focus has been more on institutions, financial services companies, and so forth. My focus is heavily on the individual as well. And I thought it would be really good to start out and think about, well, all of the things that are happening as a result of this pandemic, how would they impact retirement security and some of the risks? And in the US, there have been a huge number of job losses, temporary layoffs, as well as pay cuts. When you put those all together, they impact retirement security for the individual, the ability to accumulate benefits in their programs, the chance that they're going to be spending the money that's been accumulated for retirement. And likewise, we have the asset side and decline in equity values, fluctuations in equity values. Within the US, and this aligns with some of the other presentations, people are in very different situations. And if we think about a group of people as being financially fragile, and that's many of the very low income people, but it's not only necessarily low income people, they would be, some of them, in total and complete crisis, and their retirement savings are in big risk. We've had within the US, and I think the same in other countries, many deaths in nursing homes and other communities that combine personal care and housing for retirees. These communities have generally not allowed visitors during the pandemic. There's a big decline in consumer confidence. There's federal legislation to allow people to withdraw on a more liberal basis money from defined contribution savings retirement plans, either withdraw it or borrow it, and employers can adopt provisions or not. And employees are rightly concerned about retirement security. So it's a whole different way of looking at this, but there are huge issues here. Next slide, please. So for the financially fragile employees, I don't want to go through all these points, but I guess the main thing I'd say is that we have a real crisis, that there's a big segment of the population that don't have emergency funds, or if they do, they're really inadequate. Some employers have financial wellness programs to try to help these people sort their way out. And generally, in sorting their way out, they're going to try to dig their hole out of this week at 1 week at a time. These are many people live paycheck to paycheck. But then from a retirement point of view, the next job for these people is to help them get, after they dig their way out, get stabilized, establish an emergency fund so they can start saving for retirement. If these people have retirement savings, it's very likely it'll get used immediately and they won't have it. Big also issue for this group in the US is that while interest rates on bonds are might be very low, and interest rates on bank accounts that provide savings might be very low, interest rates on credit cards are very high. There are other high interest rate loans that these people may have. And expense cutting and spending is a big issue here. Next slide. The short term for people that are not financially fragile, but nearing or in retirement, really is checking on their situation, looking at where they are, maybe cutting expenses or making adjustments to their investments. Scenario planning is good. They may have a liquidity issue or not, but don't panic. And for most of them, it's a kind of stay the course now. And as things emerge, figure out, should they be changing something or not? Next slide, please. We've thought about the short term, but we're also thinking about the future. And in the longer term, there's some real questions about the future of the retirement system. This has all been a disruption, and it's causing people in various places to ask the question, do we have the right retirement systems? Is there too much risk on the employee? What are employers willing to do? Should government benefits be increased? How can we improve emergency funds? I would foresee that if we have the energy for it over the next couple of years, we're going to be having a lot of discussion about these questions. I don't know at all what the answers will be. Next slide, please. In doing the SOA analysis of things where retirement and other issues got very interacted as we thought about the epidemic, one of them is family. And one of the big issues that the SOA research I've been involved in has been focused on in the last 4 or 5 years is that family is in fact a really important part of retirement security and success for very many people. And SOA research, for example, on financial attitudes by generations, and this is from a couple of years ago, shows that all the generations feel obligations to the family. People are not generally planning for family help, but when they need it, family gets very involved. COVID-19 has created many challenges for the family. There's more need to help the older people. People are working at home, their children are home, really complicated. COVID-19 has increased the need for help too. Seniors that were able to go shopping are encouraged not to go shopping and to get someone to help them. So we expect more multi-generational households, more family help, and it to be all more difficult. And we also point out that more seniors seem to be helping adult children financially than the reverse, and this will be a strain on retirees. We have a report issued in the last couple of weeks specifically on this topic. Next slide, please. One of the issues that we're working on a report on, haven't done it yet, but it's the whole question of work and retirement. Within the last, I would say 20 years, increasingly people have changed the way they viewed retirement and have started to think about work as a part of retirement. And more people are wanting to do that than don't. This was a big topic for some of our research last year. COVID-19 has led to major work disruptions. With asset drops, many people will want to delay retirement. We don't know if they'll be able to do that or not. Many won't. And the people that want to work in retirement, probably harder for them. And they'll be looking for probably reduced schedule work. So there are few employers that provide formal programs to support this. People are on their own, and we expect this is going to be a big area of challenge, and people are going to be trying to figure out what to do. We'll be having a report on this within the next few weeks. Next slide, please. One of the biggest issues that has come up out of all this, and we have a report as well, is about housing that integrates care. And that could be nursing homes, assisted living, which is a lower level of assistance, continuing care retirement communities that bundle multiple levels of assistance, living. Increasingly, we're recognizing how important housing choices are to retirement success. We think that the epidemic will lead to some changes in what people try to do in terms of best housing choices. People are likely to want to work harder to stay at home in light of some of the bad experiences in nursing homes and assisted living. And that, again, may lead to the more multi-generational households. But I would also say to redesigning the types of housing that people have to make it suitable for multi-generation, suitable for people that need help. And this be a big issue. And some of the problems in the nursing homes have been, in spite of the fact that they've had the lockdown, they've had all these cases. Staff has been a source of contagion, partly because it's underpaid, partly because they haven't had enough PPE. It's an environment where it spreads, but the residents have been isolated in their rooms for weeks, and it's still spread in many of these nursing homes. So a lot of issues here about the future of both how the homes are organized and what people do for senior housing. And now one more slide for me. The next slide, please. So there are all these questions about the future challenges now, but what are employee benefit managers doing? Our impression is that they're dealing with a short term, and that in the US, human resources people are absolutely consumed with keeping employees safe, helping them save, dealing with work at home issues, layoffs, helping them return to work, health problems, and many, many more things. For those who have financial wellness programs, there's financial help more along the way. For those without, the issues of safety, helping people work at home, layoffs, that's deciding who's coming back to the office or not. That's a lot more likely to be a big issue than dealing with retirement plan issues. They are, however, having to deal with whether to act the provisions for more withdrawal to their defined contribution plans and implement those. And employers are divided on whether to do that. There's some survey data. We'll be coming out with a report on this as well. They have to decide also whether to reduce their contributions to plans, and some are. For defined benefit plans, they've been given permission to delay funding, and many probably will. We don't really know yet what the impact on long-term funding is going to be. We certainly don't know what the impact will be on the mortality assumptions longer term for DB plans. I think most of them aren't focused on longer term retirement issues yet, but many, many are lurking. Our last slide, which is just a list of SOA resources, and we want to encourage you to use them. And back to you, Trevor. I appreciate the opportunity to share these ideas with you.
Thank you, Anna. And that was so important that we covered those issues. We've got to cover the individual as well as the institutions and the academic work. And I think you did that really well. We've had 6 super speakers. We now move into the question and answers. So I'd like to thank all of the speakers for their individual contributions, which has been such a comprehensive and I think detailed and technically quality overview. The way I'm going to handle the Q&A, just to say, to start with, we are running this webinar through to 1/4 past the hour, so that's 25 minutes to go. The last 5 minutes or so will be a little wrap up from me and the panelists. So we've got about 20 minutes for questions. I'm going to start with a question that comes from questions submitted in advance, because I think it's important that those who did submit, we look through those. And then I'm going to look at the list of questions, and we'll go to the questions in order with the most likes. So those of you who are watching and looking at everything, think which are the questions you like, and I'll use that to drive which questions we take. So the one question before then is a combination from David Bell, Drago Injik, and Michael Hammer, who've all asked about care homes and nursing homes. So I'd like a view, please, from the UK and the United States to, if I try and combine the questions, it's something like, there's been so much publicity about lots of excess deaths and deaths in care homes and nursing homes. What do you think is the biggest lesson to be learnt for the future with regard to nursing and care homes in the UK and the US? And let's start with the UK and see if either Stuart or Douglas wants to have a go at that, and then I'll either go to Ed or Anna, depending on who wishes to take the ball. So is it Stuart or is it or Douglas?
I'm happy to. Which?
Go on,
Shall I
Douglas.
go for it? I'm going to go for it. Just very briefly, it's clearly a really sad story. I think when one looks at if the question relates to causation of how this all happened, the fingers at the moment are pointing towards the clear out of people from the hospital system during the month of March, when it became clear that the emergency beds in the hospital system are going to be overloaded, and there was the testing of COVID system wasn't up and running in the UK. Those people who were moved into care homes were not tested, and that seems to have caused the transference of the virus into the care home sector, and then it was just a matter of time, I guess. If you want to take it one stage further back than that, why is it that we've had to transfer those people? That's really because of a series of political decisions about funding of healthcare that have gone over many years in the UK. It's very telling if you compare the number of emergency beds in the UK with other countries in Western Europe, that you can see that we have roughly a third of the number of emergency beds in the UK hospital system compared to Germany. That has been a declining number, whilst the aging population, the proportion of the elderly population, has been increasing. So a declining number over time as the population been aging. Anyway, it's all political, basically. It's all about the choices that we make about underfunding the health system and not providing enough infrastructure in the first place.
If I may, I'll jump in and just say I completely agree with and echo Douglas's points about the political choices, the systemic underfunding of care homes historically, and the transfer out of at-risk patients. Completely agree. All I would add was the prioritization of PPE for hospitals ahead of care homes. I think that was a big part of the problem. And also, just to take a really different tack on it, there is some quite interesting emerging evidence of a potential link between susceptibility to COVID-19 and dementia. And so it may well be, we don't know if that is associational, we don't know correlation, causation, clearly unproven at the moment, but if there is an association there, then that would mean that population was especially at risk.
Okay, thanks both of you. You're both saying the same thing. And to try and summarize briefly, because I asked, what would you do different for the future? I think the message is, sort out a new process or system, which means that you do not do any of these transfers in the way that's happened, as probably the top of the list, but there's lots more. Can I go over to the US then? Is it going to be Ed or Anna who takes the US? Anna.
I will start. I think this, you've got the same, you have some of the same issues in terms of choices, but we have issues of so much of the nursing homes are funded by Medicaid, and they really aren't getting adequate funding. The help isn't being paid well. We really need reform in the way the long-term care system is funded and the choices that people have. There were also issues about transfer. So I support the parallel issues to what was said in the UK, but beyond that, we have very big issues in changing the entire system of funding long-term care. And I think in providing different kinds of housing options for people, different kinds of care options, different social supports, and making work in those environments comfortable. It's also critical that they get priority on PPE also.
Yeah, I'll just add to that real quickly that there was really a failure in recognition that this was our most vulnerable population. In addition to the age of many of these people, they were isolated. So any introduction of a virus in that setting was going to spread fairly quickly. And the comorbid conditions that many of these patients were exhibiting just exacerbated the problem. It certainly was a political issue in the US as it appeared to be in the UK. But I really think the failure was in the understanding of how vulnerable this population was.
Thanks, Ed, and thanks, Anna. Just a very quick follow-up, which is, I'm always told that there's much more variation in the United States than in the United Kingdom between your states. Are you giving an answer there which is nationwide, or does it vary enormously?
It varies enormously by state, and we don't really know. There's also an issue that the regulation of nursing homes, continuing care, retirement communities varies enormously by states as well.
Thank you very much. Right, so we do have a definite first question to answer from the Q&A, which comes from Norma Cohen, and I will read it out. With respect to mortality differences among ethnic groups, has sufficient account been taken of variables which might be more difficult to measure, such as employment, which requires high levels of interaction in closed spaces, e.g. high infection rates amongst transit workers, multi-generational households? And I think I'll, to be fair, I will go to the United States first, and on this question about ethnicity. And is that you, Max, or is that someone else?
Well, I can get started, and maybe Ed or Anna will jump in. I think, you know, in the U.S., the essential workers who have been, you know, really doing a great job, along with the healthcare workers, you know, they're part of the essential group. They do tend to have a higher percentage of ethnic folks working in them. And so they do tend to be exposed more than those of us who are, you know, in white collar jobs that we can go into lockdown and work from home and stay at home for weeks. I mean, I filled up my gas tank last week for the first time in 2 months. You know, it's something that they don't have always the opportunity or the ability to do that. I think some of the stories that we're starting to see now, though, I'm more worried about the poverty side of the equation. There was a story out of Chicago, one of our largest cities on the Great Lakes, where they were looking at an area and they were trying to decide, you know, what was the driver of why this community had such high COVID-19 number of cases. And they, you know, they started off saying, well, you know, there's a lot of Black people live there. And then by the time they were done, they were talking about, well, Chicago is also a crossroads for the trains. You know, trains go north and south, trains go east and west through Chicago. And that this area, you know, is right next to the tracks. And so the soot in where they live is way off the charts bad. And so that's another factor that causes this virus to take hold in your lungs, is if your lungs are weak to start out with. So I think there's a lot of things that are going to keep a lot of grad students busy for a generation. It looks like Ed and Anna both have their mics on, so it looks like they want to jump in.
Yeah, I'll just jump in. I think there's a strong connection between poverty and health status. If you don't have access to quality and healthy food, you're going to be less healthy and therefore less susceptible to any of the diseases, the chronic conditions that we have. And I think that what's happened now is that COVID-19 is just highlighting those more because we're actually able to see the deaths. Actually, the biggest ethnicity that has been impacted in the US is the Native American population, which, you kind of go back to when the country was founded, that smallpox decimated many of theirs because their DNA just weren't used to it. So part of the question, I think, is ethnicity, but I think a big factor of this is really kind of the poverty level. And I think we're at a point where it's still hard to differentiate between the two.
I think there's another big issue in the US associated with the poverty level is what kind of healthcare do you normally have access to, period. And a lot of the people are uninsured or on Medicaid, and they don't have access, many of them, to the same types of healthcare and the same quality of healthcare that other people do. Also, when you're talking about social distancing, if you're talking about households that have a lot of people in a small area, even if they try very hard to social distance, they're just in a much more difficult situation. So it all compounds.
Thank you. That's a very comprehensive view and lots of information I wasn't aware of. I'm looking at the UK. Who has got their mic? So Stuart, I think you're ready to speak, and then we'll see about Douglas or Caroline.
Happy to make a few different points. So firstly, just on Norma's question specifically, we're no longer at the stage where we're just doing naive one-dimensional analysis. So very early in the pandemic, we only really had the data available to look at variables one at a time. So you could compare men to women, you could compare Asians to white people. But we didn't have the ability to do multivariate analysis where we look at everything together and we see what still matters. We are at that point now where we've got those big multivariate studies available, and Douglas and I both pointed to the Open Safely study earlier. Now that's a really important one to look at, and you can see from that in the UK, even after you control for medical variables like pre-existing conditions, even after you control for poverty, such as deprivation deciles, and even after you control for various other factors, you still see this strong ethnicity effect, a significantly elevated risk for Asians, for Blacks, compared to people of white ethnicity. So that's a really interesting point. The other one I would draw out, and I think it will have come across actually to those that listened to what our US colleagues have said, there seems to be different relationships between the ethnicities in different geographies. So the Americans said earlier that Asians are at lower risk in the US than the white population. We find the reverse here in the UK. We find they're at significantly higher risk. And actually, when you look at other geographies, still, if you look in Asia, you generally find that the population there has had much lower mortality rates than we've had here. So there are all sorts of dynamics here. The very specific point that Norma made about looking at variables such as employment type, no, I don't think that data is available just yet. But clearly these multivariable studies will improve over time.
Thank you very much, Stuart. And looking at the panel, I think we'll move on to the next question. And we'll see how much time we have after this. So firstly, just to say thank you very much, Norma. If you're still on if you're still watching the show, great to hear from you. The next one is another person I know, David Miles, who has written, with regard to future mortality longevity, what is the panel's view on whether the huge amount of research currently being done on CV19 might lead to huge breakthroughs in understanding how disease affects the human body, and therefore a big improvement in longevity. And so since she hasn't spoken yet, and I'll just waffle for a little while to give her time to get her thoughts together, I'm going to start with Caroline.
Hi there. I think that's a really good question. And I think it really just goes back to my apologies. We don't know yet. And if you just kind of think to the slide where I had all the up arrows, all the down arrows, there's going to be so many things that could go either way. And there really will be kind of your indirect impacts. I mean, I was at a conference a couple of weeks ago. And so in America, especially, we have lots of researchers who are doing lots of work into trying to solve the problem of aging, which you kind of think, well, how can this have an impact? But you go back and you look at our data, which shows that one of the biggest risk factors is age, potentially because our bodies are not as able to deal with it. So even a science such as that if there is advancements in that, again, that could have a consequence on something like a pandemic like this, which is impacting the older generation. So yeah, so apologies for not having a definite answer, but I think that's a really good point. And again, it is going to take years before we really do see all these consequences. And so there's no quick answers, unfortunately, for a lot of these questions.
I'm looking to see if anybody wants to jump in and actually have a go at any type of answer. Ed.
Can I, Trevor, have
I'll just make a quick statement that I will make a prediction here that this will have an impact on how we do research going forward. I think for the first time, we've been able to identify that there are different characteristics of individuals which have had different impacts. Some are 50 to 80% of the population who've been infected by COVID-19 are asymptomatic, so don't contract it. We've certainly come a long way since the pandemic of 1918. We've been able to sequence the DNA. I just think this is going to open up a huge area of research, and it's going to expand into areas where we'll be able to identify how people are affected by things other than COVID-19, like other health conditions and other comorbid and chronic conditions.
Thanks, Ed, and I'm inclined to agree with you, but I would fully support everything that Caroline has said, which is we don't know at the moment, and it is going to, we've got, lots of very sound advice from Caroline on the things to look at, and thank you very much to both of you for that. I think I'll take the one final question on here, or the next one, and just purely because it's at the top of the list here, it looks like it's one for Douglas, which says, what about higher mortality rates relating to commuter corridors, such as users of the Northern Line tube in London? I want to know what's wrong with the Northern Line rather than any of the other lines. But over to you, Douglas.
Well, I think there's overwhelming evidence that you get this disease if you're exposed to other people who've got it. So I don't think there's anything remarkably different about commuting lines, other than it's a high density situation, which if you were being prudent, you would wish to avoid. And funnily enough, just kind of got a notification on my phone as just literally 2 minutes ago, saying that the UK government has announced that the wearing of face masks on public transport is going to become compulsory. So I think kind of as there seems to be some cultural inhibition to wearing them, that the government's had to enforce that process. But I'd say I think the issue is not public transport per se. It's mixing with other people.
Thanks, Douglas. Anyone want to add anything from the US? No. The only thing I would add is to everybody, you hear it first on ILC for the breaking news. Actually, I said to my children in March, the UK is going to be making face masks compulsory before this is out. So maybe not first on the ILC, who knows. Right, I've got one final question which I want to ask all panelists, and then I shall do my wrap up. So My final question, which they haven't been warned about, I want a quick answer from each of you, please. What, in relation to COVID, what makes you stay awake at night? Let's start, we'll do one after the other. So the first on my panel is Ed, and then we'll do Douglas and then Anna. So Ed.
Yeah, I think what keeps me awake at night is the inconsistency in the data that we have. And I think we as actuaries can do a lot to have an impact on that going forward. Our ability to understand what's going on, our ability for clinicians to have good information, the ability for politicians to make appropriate decisions has been impacted by the data quality and the lack of data that exists. So I think it's incumbent upon the actual profession to take a stand in a position on this.
Thank you. Douglas?
Well, for me, I guess it has to be a personal one. My 84-year-old father, almost 85-year-old father, is towards the end of his days, suffering from dementia, Alzheimer's disease, in a care home in Scotland. And I guess if I think about anything, it's him at night.
Yeah, it affects a lot of us, that does, a very important one. Anna?
Well, the bad policy response in the US is absolutely horrifying. I'd say that's number one. Number two, the very large number of people out of work and a fear that we're going to have a lot more increase in cases because we've been opening up too fast and people haven't been wearing their face masks and we're not doing a good job of managing things.
Stuart?
So a few things. Firstly, from a UK and US context, a second wave with a non-compliant population. I think government actions and actions of government advisors have potentially led to a situation where people will be less compliant with control measures if there is a second wave. I worry about the long-term consequences of this disease. So for Spanish flu, for example, we saw people that were exposed early in their life had cardiovascular problems later in their lives. So who knows what's to come in the years ahead, and particularly for children who so far haven't seen extreme effects, there could be consequences later in life. And I still worry about what we may see in the developing world. We've talked very much in a first world UK, US context here today. And so far, we haven't seen too much of the horror that was feared in the developing world, although the situation is getting bad in South America.
Thank you. Max?
Yeah, I'll go a little bit broader on my comments. I mentioned during my presentation that I work a lot on emerging risks. And so what keeps me up at night is thinking about these combinations of emerging risks. So, I mean, I've done, pandemics. I mean, this is not the big one. This is a fairly mild scenario relative to what could happen or what did happen in 1918. So we need to keep that in context. But, I also have done work on climate change, looking at the situation financially that we're in with high debt, with low interest rates. I think it's really important that anybody who's a risk analyst do scenario planning in terms of looking at what could happen, even if you're doing it qualitatively and not trying to get too deep into the numbers. Do you think about, how should I prepare, or how should our country prepare, or how should the world prepare for these events that are likely inevitable at some point?
And finally, last but not least, Caroline.
Hi, yeah. So again, I'll have two, a kind of a work-based one and a personal-based one. And I think on the personal-based one, I think obviously, I think lockdown was the absolute right decision to make, but I think it's having a lot of unintended consequences. And actually, I have teenagers, and actually, I'm very worried about the impacts that people about age 17 to 22 are going to see. So universities potentially not opening for a year, what their job situation is going to be like. So I think that's a worry. And personally, I think, again, we're being asked I think people are expecting to potentially see life insurance companies making huge changes to their assumptions. And I think, how do we get that message across that actually it really is an emerging situation? There's not going to be, I can't personally see a quick response happening to this, because I think we do need to operate a wait and see a little bit on our assumptions, because I don't think we can say too far ahead what the impact is going to see yet.
So thank you, all of you panelists. I think you've done a brilliant job. And it's shown by the large number of attendees who are still listening. So just some very quick closing remarks. Thank you to all the panelists. Thank you to all the attendees for making it such an important and an interactive session today. I've really enjoyed it. Thank you also to the Institute and Faculty of Actuaries and the ILC Partners Programme for making this webinar possible. Members of the Partners Programme benefit from a range of opportunities, and they should be coming up on your screen as I speak. However, I won't run through these in detail, but do take a look, because I think if you've enjoyed today, think about how you can enjoy things further. This has been our 7th webinar in a series of webinars on the impact of COVID on an aging population that we are planning over the coming weeks and months. Next Thursday, we'll be hosting another webinar, Canary in the Coal Mine, Learnings from COVID-19 for Health Ecosystems in an Aging World. And if you're interested in sponsoring an ILC webinar, then please get in touch with ILC's Head of Partnerships and Development, Redvers Lee. Moving on, this year's Future of Aging conference, held on 3rd of December, will explore how we can ensure policy and practice works for today, for today's as well as tomorrow's older and younger people. Confirmed speakers so far include Jonathan Porritt, Vibar Craig and Reed. Make sure to register now at the address shown to make the most. For news of our latest webinars and to stay up to date, please visit our website at ilcuk.org.uk, join our mailing list and follow us. And finally, we hope to welcome you all at another ILC webinar or event in the very near future. Thank you, everyone, and goodbye.
Thank you.